How are you, Dr. Clifton? Hi.
Do you want me to put my computer? I don't need my
I
laptop.
already know.
Perfect.
And it's recording, if you don't know.
Yeah.
Thank you.
I sent you the link this morning? We don't have any medical students right now. Oh, that makes sense, holidays.
It's their first day,
Okay.
so they'll probably get.
Okay, well then,
And their second year.
you're, no, I'm just kidding. There was definitely some like med student heavy, like, what antibody questions that I'll just open to the whole room. Thank you. Yeah. I can see my face clearly on this screen. Oh, Michaela. Yeah. Oh, yeah, big candidate. All right, we'll get started. Thanks for being here, Gabs. All right. Great. Okay, guys, thyroid today. Oh, screen already went black. Okay, so do I just split?
I think that you have to move the mouse over that screen, which is
The opposite direction of what I would expect. Okay, of course.
And then like, it looks like I put it on the right side of the screen.
Yeah. Okay. All right, this is our agenda. Just as a heads up, this is going to be quite interactive. Feel free to just shout out answers. I won't call anyone specific unless I need to. So let's start with the anatomy that's relevant to the thyroid. Who can tell me what the arterial supply to the thyroid is? It is on the screen if you don't know. Yeah, okay, who can tell me where the superior thyroid artery comes from?
Say what they just said.
Okay. Thanks. Okay, so the superior thyroid artery, where does that come from? Does anyone know what it branches off of? Yeah, the external carotid. Okay, and the inferior thyroid artery? It's from the thyrocervical trunk. All right, and then you also have the IMA artery, which supplies the isthmus, comes off of the innominate. Only about 1% of people have this. Now for the venous drainage, you have your
Superior, middle, and
yeah, superior, middle, and inferior thyroid veins. And the superior and middle will drain into the internal jugulars and the inferior into the brachiocephalic. Now there are two very anatomically relevant nerves that are around the thyroid. Anyone? Yeah, the recurrent laryngeal and the superior laryngeal. So your superior laryngeal innervates the cricothyroid. It runs lateral to the thyroid. The recurrent laryngeal, on the left side, it loops around the aorta. On the right side, around the brachiocephalic. Gives motor innervation to all of the larynx except for the cricothyroid, obviously. And it runs posterior in the tracheoesophageal groove. Okay, let's do some quick hits. So if you have a left-sided non-recurrent laryngeal nerve, what other anatomic variation is associated with this? Yeah, so your right-sided aortic arch. What about a left-sided non-recurrent? Or, sorry, right-sided non-recurrent. Yeah, so this is associated with an aberrant right subclavian artery, and it commonly goes retroesophageal. I know this question was on our practice test. Okay. Does anyone know why we should ligate the inferior thyroid artery close to the thyroid when you do a thyroidectomy? So the inferior thyroid artery does supply the parathyroid gland, so you want to avoid ischemic injury, so ligate as close as you can to the thyroid. Anyone know what the most common nerve injury is following a thyroidectomy? Not like this is common, but it's the most common. Which of the two nerves do you think is more commonly injured? Yeah, the superior laryngeal. Does anyone know where this is commonly injured at? Yeah, so up at the superior pole, usually during ligation of the superior thyroid artery. What does injury to this nerve cause? Interns. Yeah, difficulty with projection, voice fatigue. Okay, what about the recurrent laryngeal nerve? Who can tell me what happens if you injure this? Yeah, so hoarseness unilaterally. What about if bilaterally? Yeah, airway obstruction. Does anyone know where this is most commonly injured? What was that? Yeah, it's near the ligament of Berry because it runs kind of behind the thyroid there.
The only other thing is, this is the fact that I didn't realize this until I've seen these, but as much of hoarseness as it's a bad injury, the aspiration.
Okay, yeah, Dr. Clifton's saying that if it's a bad injury, other than just hoarseness, you can get difficulty swallowing. And okay. All right, you're performing a subtotal thyroidectomy and you want to leave the tubercles of Zuckerkandl behind. Does anyone know why? There's something that runs close to them that you don't want to injure. All right. Okay, interns, if you are seeing a post-op thyroidectomy patient and they have stridor, what should you do? Yeah, evacuate the hematoma at bedside. This is an emergency. Okay, so now moving on to physiology. This is just a brief review. So your thyrotropin releasing factor will come off the hypothalamus, act on the anterior pituitary to release TSH, which then acts on the thyroid. T3 is your more active form. Frank, what'd you do? I'm kidding. And normally, so T4 is what's normally in circulation, and the majority of T3 is made from peripheral conversion of T4. You also have calcitonin that acts on this, or comes from the thyroid, which acts to reduce your calcium levels. All right, so embryology. Does anyone know the embryologic origin of the thyroid? Yeah, first and second parental arches. It also primarily comes from endoderm. The parafollicular C cells all are actually mesoderm. But the important thing for embryology is to know that there are issues that can happen during thyroid descent in embryogenesis. So the most common ones that will be tested on are lingual thyroid and thyroglossal duct cysts. So for lingual thyroid, this is just undescended thyroid tissue. Usually when patients have lingual thyroid, they'll have an inadequate thyroid hormone production, and they can sometimes get enlargement, which can turn to compressive symptoms in the upper neck. So in order to treat this, if they do have inadequate thyroid hormone, you obviously give them thyroxine and surgical excision if there is compression issues. For your thyroglossal duct cyst, this presents as your painless midline neck mass near the level of the hyoid. And these can become infected. They can also form fistulous sinuses to the skin. There is a risk of malignant transformation. So you treat these with the cyst trunk procedure, which means that you remove the mid portion or all the hyoid along with the thyroglossal duct cyst. And you want to always resect these if found because of that risk of malignant transformation. Okay, so now we'll move on to hyperthyroidism. So common symptoms, obviously weight loss, heart palpitations, heat intolerance. If they have a large goiter that's causing hyperthyroidism, you can see some of the like thyromegaly, tracheal deviation, tremors on exam. The most common cause is Graves' disease. And then after that is your toxic multinodular goiter and then solitary toxic nodule. For hyperthyroidism, you'll see suppressed TSH and elevated T3 or T4. So Graves' disease, this is an autoimmune disease against the TSH receptors. It can be diagnosed by measurement of these antibodies. You'll also see diffuse uptake of radioactive iodine on scans. The treatment is first medical with PTU or methimazole. You can also do a radioiodine ablation, and then sometimes surgical resection may be necessary. So for surgery, this is for patients who also have, with their Graves' disease, nodular thyroid disease or large goiters, or patients who develop severe cases of thyrotoxicosis. And then I did mention radioiodine. Does anyone know the contraindications to radioiodine? Pregnancy, breastfeeding, I heard allergies, what? Yeah, exophthalmos. It can make eye disease worse. So, and then if the patient was pregnant, you want to make, or are planning on getting pregnant, you want to make sure they wait at least 6 to 12 months after their therapy in order to become pregnant, because you can risk cretinism. Okay, quick medication review. Does anyone know the mechanism of action of PTU? So there's kind of two mechanisms here, but really it blocks the thyroid peroxidase enzyme. So you prevent the gland from producing the hormones. It also does prevent conversion of T3 and T4 in peripheral tissue. What about the side effects? Yeah, agranulocytosis and aplastic anemia. Okay. How about for methimazole? So it is also a thyroid peroxidase inhibitor. It does not prevent conversion in the tissues like PTU does. Side effects of methimazole? Yeah, the same, basically, and cretinism as well. So in which one is safer in pregnancy? PTU. Yeah, exactly. So it doesn't cross the placenta, so it's safer in the first trimester. After the first trimester, you can use either methimazole or PTU, but this would probably be seen on the exam. It's safer to go with PTU for pregnancy. Okay, thyroid storm. This is a dangerous constellation that can happen with hyperthyroidism. You'll see tachycardia, fever, irritability, vomiting, diarrhea, pulmonary edema, heart failure. Treatment for this, so beta blockers are important because of that heart failure. You can also give PTU and methimazole. However, they do act slowly, so that shouldn't be your only medication that you give. Lugol solution, the same thing, is effective, but does take a while to work. So you want to give some supportive therapy while you're giving these medications. So cooling blankets, oxygen, dexamethasone. This was on our practice test as well. So this inhibits peripheral conversion of T4 to T3, so it can also be used for thyroid storm. Okay, anyone know what the most common cause of death in thyrotoxicosis is? So it is the high output cardiac failure. Okay. How about the most common cause of thyrotoxicosis? When do you see this most frequently? What'd you say? Drug-induced can cause it, but the most common cause is going to be a patient who doesn't has undiagnosed Graves' disease and then undergoes surgery for something else. This will stimulate them to go into a thyroid storm. Okay, so pre-op preparation for a thyroidectomy for hyperthyroidism. So the first thing you want to do is make sure you achieve euthyroid state. So this is normally done with methimazole. And then if a patient does have, some other constellations of hyperthyroidism, you can start beta blockade. It's not necessary. For some surgeons will elect to give Lugol solution before their thyroidectomy. This decreases the thyroid vascularity. It also makes it firmer and easier to resect. It is given oral pre-op, usually in water or juice, and that's done for about 10 days. And then a voice assessment. So this is necessary to do with all patients. So this really is just getting a good history and physical. So do they have any history of voice changes? Have they had prior neck surgery? And do an objective assessment of their voice, so you know what they sound like, so you can then compare post-op. Laryngoscopy is a good tool, but it's not necessary in everyone. However, if someone does have a history of voice abnormalities or has a history of neck or upper chest surgery, you will want to get a laryngoscopy just to make sure that their vocal cords are functioning appropriately. Okay, thyroiditis. This is kind of low yield. The most high yield on this slide is Hashimoto's. So this is the most common cause of thyroiditis. What antibodies do we see in Hashimoto's? Yeah, so the TPO. These patients they'll develop hypothyroidism, enlarged glands, that's painless. It's most common in women. It can also be seen with a history of radiation therapy. On pathology, you'll see lymphocytic infiltrate. That is an important buzzword for the exam. Treatment, first line is thyroxine. And then if their thyroid continues to grow or nodules appear, then you'll want to do a subtotal or total thyroidectomy. Bacterial thyroiditis is very rare. This is due to contiguous spread from usually an upper respiratory infection with staph or strep. You'll see normal thyroid tests, but they'll have fever, dysphagia, and tenderness, and you treat this with antibiotics. If there's any concern for cancer, like you see unilateral swelling or something abnormal, then you'll perform a thyroidectomy. Deucravacine's thyroiditis, this is that viral upper respiratory infection precursor. They'll have a tender mass and a sore throat and weakness. You'll see an elevated ESR on your labs. This is treated with steroids and NSAIDs. And then Riedel's thyroiditis is that woody fibrous thyroid. It can resemble thyroid cancer or a lymphoma, so you may need to biopsy it. This is treated with steroids and thyroxine because it does cause hypothyroidism. If there's any concern for compression syndromes, which can happen frequently with Riedel's, you'll want to do an isthmectomy or a tracheostomy for airway symptoms. All right, thyroid nodules. So the diagnostic evaluation of a thyroid nodule, normally they're found incidentally or on physical exam if they've got a lump. The first thing you want to do is check that TSH and get an ultrasound of the neck. So if your TSH is suppressed, then confirm with a thyroid scintigraphy scan. If it's a hot nodule, if it takes up that thyroid, then the patient is appropriate for a radioiodine ablation or surgical excision. If it's cold, then that's more concerning for potential malignancy. So if there's any ultrasound findings that are irregular, or if it's cold nodule, so the irregular findings such as hypogenicity, microcalcifications, irregular margins, lymphatic invasion, then you want to proceed with your FNA. Your FNA will then guide you with what you want to do next. So, but first let's talk about an FNA that shows cyst fluid. So this, then you'll want to drain the fluid and send it to cytology. If the cyst recurs or if the fluid is bloody, then you will want to perform a lobectomy to remove the cyst. If the FNA shows colloid tissue, it's most likely a colloid goiter. These are very low likelihood of cancer, so you can just treat with thyroxine. And if they do continue to grow, then you will want to perform a lobectomy. So for those toxic adenomas or multinodular goiters, the ones that light up on your scintigraphy scans, the treatment options include surgery, radioiodine ablation, or your antithyroid medications. Surgery is your best option and should be performed if the patient is a good candidate. If not, you can do the radioiodine ablation or treat with antithyroid medications, which are not a great treatment option, but for someone who can't withstand the radioiodine or surgery, that is kind of your only option. Okay, so now we'll get into thyroid cancer. It's the most common endocrine malignancy in the US, not very common. Well, I guess some papillary is pretty common. Generally does not affect your thyroid function. So if you're seeing issues with TSH, thyroid, it might be something else. Things that are worrisome for malignancy, a solitary nodule, slow growing, if they're hard, if it's found in a male, especially over the age of 50, they've had a previous neck radiation, or if they have one of those MEN syndromes. Sudden growth can indicate hemorrhage into a previously undetected nodule or malignancy. That's something to consider. And patients can also present with voice changes or dysphagia, which is a pretty bad prognosis. So we'll just review the Bethesda criteria. So Bethesda 1, so this is non-diagnostic, and you'll want to repeat your FNA. Bethesda 2 is benign, so you can just follow up with ultrasounds. 3 is where you'll get atypia of undetermined significance or follicular lesions of undetermined significance. Per the guidelines, you can either repeat an FNA or do ultrasound follow-up or lobectomy. Per BTK, most likely what would be the correct answer on the exam would be to repeat the FNA. Bethesda 4 is suspicious for follicular neoplasm, so that's when you want to start performing your surgery. Up to 5 is suspicious for malignancy, and 6 is malignant. And then if that is what you're encountering, then depending on which malignancy determines what kind of surgery you do. All right, so papillary thyroid cancer, the most common. Is it more so found in males or females? Females, okay. About age range? Yeah, so middle-aged female. What can you see on your FNA? Like, what is the pathognomonic for it? Yeah, Orphan Annie and the Samoa bodies. How does it spread? Through the lymphatics, yeah. It has a pretty good prognosis, and then treatment is surgery. So this is what you should be able to identify on the exam. They might show you a picture of this. Clinical staging for papillary thyroid cancer. This is a very simplified version. Important to remember that it is age determined. So for stage 1 and 2, those patients are less than 55 years old. They have no distant mets, then it's stage 1. If they do have distant mets, it's stage 2. And stage 3 and 4 are in your patients that are older than 55. So what surgery do you perform for papillary thyroid cancer? So you can perform a lobectomy or a thyroidectomy. So this depends on a few things. If the nodule, they say less than 4 centimeters, to me that's pretty large, or without nodal involvement, you can consider a thyroid lobectomy. For a total thyroidectomy, there are some advantages to doing this. It does allow for surveillance of your thyroglobulins. You can get your post-op radiation or radioiodine treatment. You can't do this if they still have thyroid left, and then removal of any potential multifocal disease. Now, it's pretty rare that you'll need to dissect lymph nodes out when performing surgery for papillary thyroid cancer, but the reasons too would be if there's any suspicious lymph nodes, central lymph nodes, you would do a level 6, and any lateral lymph nodes would be 2 through 4. Okay, follicular, this is the second most common. Is it more common in males or females? Females, yeah. What about age range? It's also about middle-aged, 40 to 60. Let's see. How does it spread? Yeah. Through hematogenous, not lymphatic. Also has a pretty good prognosis, and surgery is the treatment. Follicular cells are thyroid hormone producing. So surgery for follicular thyroid carcinoma, for the most part, this is a total thyroidectomy. If you have any positive nodes, so you'll want to epinate any suspicious nodes, then you'll need to perform a modified radical neck dissection. And these patients can also get post-op radioiodine treatment. You can consider a lobectomy instead of a total thyroidectomy if they are less than 45, have less than 4 centimeter nodule, there's no distant disease, no family history of thyroid cancer. Okay, medullary. What population of people do we see medullary thyroid cancer? What gene mutation? Yeah, the Rett. So MEN2 syndrome patients is probably what you'll be tested on the exam. So these ones do produce calcitonin because they come from your parafollicular C cells. You can also see amyloid deposition on your FNA. They spread lymphatically, and a lot of times they will already have METs at the time of diagnosis. Prognosis isn't great, 50% 5-year survival rate, and they obviously also need surgery. So this is going to be a total thyroidectomy with a central neck node dissection. And then if there's any concern, you also want to do, let's see, I go back. If there's any concern for lymph nodes, you'll also then extend to a modified radical neck dissection. Before you do surgery on these patients, if they don't already have a known diagnosis of MEN2, you want to make sure you screen for hyperparathyroidism and pheochromocytomas. If they do have any distant mets to the liver or the bone, they are not curable, and you'll want to consider palliative therapy at that point. And then these patients, once they do undergo surgery, you can surveil them with calcitonin and CEA. Okay. So the last one, anaplastic. So this is really rare. It's seen in patients that are over the age of 65. They rapidly metastasize and they have a very poor survival. And then we'll do a total thyroidectomy for these if they have resectable disease, but as mentioned, resectable disease is rare in these patients. So normally you're doing a palliative thyroidectomy for any compression symptoms or palliative chemo and radiation. Okay, last thyroid cancer is our thyroid lymphoma. So just like with the other thyroid cancers, you'll diagnose with an FNA. You'll see large irregular lymphoid cells on your FNA. And then treatment for this is chemotherapy. So usually R-CHOP. They respond really well to this. However, if there are any compression symptoms, you can treat with radiation, not surgery. So we'll do a quick review of the MEN syndromes. So MEN2A and 2B is where you're going to see thyroid pathology. You'll see medullary thyroid carcinoma. The MEN2A, you'll also have the parathyroid hyperplasia and pheo. For 2B, mucosal neuromas, marfanoid, and pheo as well. So when it comes to having a patient with known MEN, when do you perform a prophylactic thyroidectomy? This is dependent on the specific gene mutation that they have. MEN2B is the highest risk. Usually it encodes a codon M918T. And so patients with MEN2B, you'll want to do as soon as possible or within at least the first year of life. The low, medium, and high risk can be done until 5 years of life. If they don't want surgery, or yes, their parents don't want surgery, you can delay if they have normal annual calcitonins, normal annual ultrasounds, and a family history of less aggressive medullary thyroid cancer. But for the most part, 5 years of age for MEN2A and 1 year for MEN2B. Okay. What thyroid malignancy cannot be treated with radioiodine ablation? Yeah, medullary thyroid. And that's because it comes from the parafollicular C cells, which are mesodermal in origin, so they don't absorb iodine. What is usually the first symptom of MEN2A or 2B? What'd you say? No, normally it actually presents with calcitonin elevation and diarrhea. What group of nodes are found within the anterior suspensory ligament? And what is their significance? I heard it, Delphian nodes. So these are normally the first site of METs for thyroid cancer. They're in level 6. All right, I have like 5 questions. Do I have a volunteer who wants to take the first one? Yeah. So the imaging shows some concerning features for cancer, so you want to get the FNA. Next, go ahead.
As medullary thyroid carcinoma, mucosal hepatitis, found to be positive for breast that added to a thyroid.
Yeah, so this patient has MEN2B, which is highest risk. So the surgery for that is the total thyroidectomy with central node dissection. Yeah, don't get tripped up by just thyroidectomy or subtotal. They also need that central node dissection. Yeah. So D is describing those orphan Annie eyes. So the solid sheets that don't contain colloid is what you can see in follicular carcinoma. Hypercellularity and eosinophitic cells is Pearl cell. Medullary thyroid carcinoma, you'll see the infiltrating neoplastic cells that are heterogeneous, and then your spindle and giant multinucleated cells are anaplastic. One of the interns you want to try?
53-year-old female with no significant past medical history is found to have hyperthyroidism on lab tests after workup for tachycardia and weight loss. Ultrasound on the neck shows a solitary 1.2 centimeter right thyroid nodule. Scintigraphy shows focal uptake corresponding with the nodule, which of the following is most definitive management for this patient's disease risk of recurrence. Really?
So what's their diagnosis? Yeah, toxic nodule. So what are the treatment options for a toxic nodule? Yeah, so you can do surgery, you can do medication, you can do radioiodine. So the question's asking which one has the least risk of recurrence. So, yeah, so you'd want to remove it. So thyroid lobectomy. And then pre-treat with methimazole, make sure that they're euthyroid. It's just to consider before going. They don't necessarily need beta blockade, but it's not a wrong answer. Okay. I think there's one or two left.
4-year-old female presents with a small palpable non-tender lump in the left central neck. And she's noticed for the past year, it's not changing size. Significantly. You say she's normal, challenge that well. She's in medical search history, family history, includes grandmother breast cancer, which follows likely back.
Let's say those microcalcifications
Is
in
that
there.
there?
Yeah.
Uh,
Follicular. Yeah, papillary is the most common cancer. So yeah, the ultrasound's not great, but you're supposed to be showing some like microcalcs and hypoechogenicity. So I'm gonna-
It's not specific, because there's got more gray on the inside, right? It's a
Yeah.
Simple, like, when you watch the fluid.
Yep.
I think the left is showing like not compressed and the right is showing more compressed. And these nothing about farther, so when you try to compress it, they're taller than it is wide, that's what I think that's what we want to show.
Mm.
It's not compressible, so the
Yeah.
whole thing will go down, so it's like this big, it should be more compressible than that, so it's wider as you compress it in the hyper cell.
Yeah, so just for the computer screen, what Christina was saying is that you know it's not a cyst because it's not full of fluid, and then you can see what they're trying to show is compression, so it doesn't compress, you know, it's hard nodule. All right. Galen, I think you're up.
A patient goes to office for post-op care after thyroidectomy surgery, secondary personal and vascular engagement. Patients do long ask for the next steps for care will be, which is calling to for a break consent. Freedom is found every 6 months, 2 sets for recurrence, chemo radiation, radioactive iodine, or initiation of the. I think for the vascular engagement, you want to do radioactive iodine, and then you would.
So yeah, the answer is radioactive iodine. The main reason though is this patient has follicular carcinoma, which responds well to radioactive iodine. So patients with papillary and follicular who undergo total thyroidectomy are candidates for radioactive iodine and should get that. All right, that was it. Okay. Ugh. Oh, other way, isn't it? There's the mouse right there. Okay.
Okay, so. Stop the share.